All right.
Our screens on there. Good evening. I hope everybody was able to join. We had a couple of people join us late, so I apologize for getting on a couple minutes late. But we'd like to welcome you to the very first Aesthetic Authority and Durham Times Roundtable. I'm excited to moderate tonight's session, and I'm going to introduce my panel in just a moment, but I'd like to thank Eliza Cabana and Amy Ammon, who is the publisher of Durham Times and Aesthetic Authority, and Eliza Cabana is the editor of Aesthetic Authority. It's a new publication, a sister publication to Durham Times and Ophthalmology Times, and I'm honored to be the medical advisor, thus my role this evening. We also have developed over the last couple of weeks, many of you have visited Facebook discussion site called Coronavirus in the Private Practice. It's been very helpful. Have over 100 people that view that and get ideas from one another. But tonight we have a panel that represents the northern part of the country, the southern part of the country, eastern part of the country, and even the western part of the country, Catherine. And we're really happy to also have someone that represents the legal profession and a practice consultant on the phone. So we have a lot of brain power here to try to work out some answers to some dilemmas that many of us have had in trying to, number one, close down our practices, number two, preserve our practices, and number three, figure out how we're going to reopen our practices, which we hope to open very soon. I'm going to introduce our panel, starting, I think that, I'm not sure if Dr. Moss is on the line yet, but I believe he is, and that's Corey Moss, who's a facial plastic surgeon from San Francisco, Ross Clevens, facial plastic surgeon from Melbourne, Florida, Amy Taub, dermatologist from Chicago, Mark Nestor, dermatologist from Miami Beach, Steve Perlman, facial plastic surgeon from New York City, Allison Avila, who's an attorney, healthcare specialist with a large firm, Gordon Reese, and she's out of New York City, and Jason Posner, who is a plastic surgeon from Boca Raton, and I think I mentioned Catherine Maley, who is a practice consultant from the San Francisco or Bay Area. So with that in mind, let's dive into what we're going to talk about tonight and see if we can share some ideas, maybe get some ideas from one another, and then we'll have some time in a bit to field a large number of questions that we already have coming in. I'm going to start by calling on to the left, Ross Clevens, and Ross has got a busy three-person, I believe, practice, aesthetic practice in Melbourne, Florida. And Ross, you know, what's the status of your practice right now? What have you done to this point, and where are things at for you?
Well, thank you for having me, Randy. You know, like many other people, we're facing a moratorium on elective surgery, which at this point seems to be through May 7th. So when that was instituted around March 20th, we were forced to lay off about half of our staff. We put another quarter of the staff on about 50%, and about 50% of the staff have remained.
I'm trying to do a webinar,
but we've done,
are you
which
serious?
I think is very important, is maintaining our emphasis on marketing. I think this is an important time to play offense and not defense, and to try to poise the practice for the return when this moratorium comes to an end.
Very good.
I'm trying to do a webinar, but I can't.
I think that's how to speak, Allison.
Allison, we can hear you now. Can you hear us? Allison, can you hear us?
Yes, sir.
Okay.
She what?
Okay,
So I'm trying to do.
Allison,
I'm trying to get online here.
Allison,
You're not online? So how do you get online first?
Well, I'm on the presentation manager, but I'm not. They can't see me. I can't see them. Hello?
Allison?
Yeah.
Everybody can hear you on the webinar, which is live.
Oh, sorry. Okay. So they can hear me, but you can't see me.
Yes, we see you.
We see you as well.
We can see you. All right, so let's.
Go ahead,
They can't
Randy.
hear you from here also.
Because
Steve,
they're
sorry
not seeing
about
me, and I can't hear them.
Can,
Steve, same thing for you. You're in New York City. It's kind of the heart of everything. And, I have a daughter up there that's a
Why would I
resident,
be able
and
to-
it looks like total chaos. Tell us a little bit about your practice at this point.
well, New York, we saw things happen early, happen fast. We reacted reasonably fast because our governor is fairly proactive. Monday, March 16th, which was before things were shut down, most of my colleagues, most people I know, saw that this was not a good situation. Kids were out of school that day, so we shut down 100%. It wasn't until Friday that the formal shutdown came from our governor. But again, most people I know were
I'll hear you. Okay, I'm going to try and figure this out.
and stopped all activity. So patients would stop coming in, our staff would stop coming in. Since that time, we've just been doing what everybody else is doing, virtual consultations, going to multiple webinars such as these, learning what we can do, what we can't do, and some educational webinars to keep our mind sharp when we can't keep our scalpel sharp.
Very good. Well, it's not a whole lot. It's kind of like the rest of us. Let's, Jason, you're down in Florida. I know you have a large practice with a number of doctors. What's been going on in Florida?
So, we have two separate practices. So our med spa shut down. I have partners in that, and I'm a minority partner in that. So the med spa shut down as of March 20th because of the governor's ruling on no elective procedures. My last surgery was March 20th, and I came in, that was a Friday. I came in Monday morning. The first thing I did was I met with my office manager. We said, okay, how much money is in the bank? How much money do we take in from surgery? What are we going to do financially? How long can we go financially given the situation? And we took it from there. So the first thing I did is I hit the financial aspect of it, saw how many patients left deposits and paid for surgery, whether we would have to. Surprisingly, not everybody asked for their money back, so I was very surprised. We kept a wait list of patients. The next thing I did is I came up with a plan of what we're going to do by not working, which was on my surgical side, we split the staff into two. They come in every other day, and we continued to pay everybody. What we did was we went through our photo books, we went through reviews, cleaned the office, we cleaned our rooms, we went through every piece of equipment in the operating room. So we used this as a time to really make the practice better. We had multiple marketing meetings. From a personal standpoint, I've been working out every day. I went back and we wrote a couple of papers. We finished some things that we really had been working on, and we're just getting ready. So today, the governor and the president and Fauci just talked about getting us back to work. It looks like they're going to put this in phases. Phase one is elective surgeries can resume. So I'm hoping that sometime in early May we can resume surgery. We have a wait list ready to go. And we've been doing virtual consults, and I've been seeing stops, but I'm going in every day and working.
So, Amy Taub, I know you have a number of employees, a large number, and we've shared what you're doing with your employees. Can you share a little bit about that with us?
Okay, well, as of March 12th, actually, that was my last day working because I'm a little bit on the older side, and I realized that I might be at risk as well as having asthma, and I was intensely reading everything and realized that it was going to get worse and it was very bad. So I decided to stay home. But then on the 16th, I believe it wasn't much later than the 16th, that the shelter in place took effect in Illinois. At that point, looking at what we had in cash, what we had on our line of credit, I quickly realized, because I have such a large staff, that we would really only have enough for about 2 months to operate. And I thought, well, if I use that 2 months for now, we won't have anything to reopen on. So I furloughed 2/3 of my staff, or maybe more like 4/5. I furloughed like 64 people and retained 14. With those 14, what we did was the phones were actually extremely busy. People wanted to know what's going on. They wanted to cancel. They wanted to still come in. A million different things. They wanted their prescriptions refilled. We pivoted to telemedicine pretty quickly. One of the nice things about being a dermatologist is that we also do medical visits. So we did stay open for from 9 to 1, Monday through Friday, for what we called essential services, which would include, new rashes that were painful, abscesses, really concerning lesions. Sometimes it's hard to tell over the phone what's going to be concerning and not. Oftentimes we ask patients to send a photo, and that was helpful. And then we also were doing telemedicine. So we rotated our staff through at the office. We have a pretty large office, so we were able to have everybody stay away. We had patients check in from the parking lot, actually, and then we would text them when we were ready for them. And so there wasn't people waiting in the waiting room. Since that time,
that's interesting, Amy. That's really an interesting approach, because we're going to talk about a little bit that may be what many of us are doing going forward. But I did want to ask you one question, and then I'll go to Mark. I know
Sure.
You have a huge online presence for skincare products and stuff. Has that demand gone up or gone down? Just curious.
it's actually gone up, very surprisingly. What a lot of the companies did was to give us 25% off of their products. And so we decided to put everything on sale, with the exception of some products that are not allowed to be on sale. And so we put them all on sale 25%, and we did various email blasts. And so we had a huge number. We've had more sales on our internet than we've ever had before. And we also started a delivery service. So anybody within certain zip codes, we've actually been dropping their packages off like Amazon, and taking a picture of it and ringing their doorbell. And people have been loving that. So who knows, once they stock up though, who knows what's going to happen? Like maybe nobody will buy anything for the next 5 months, and they'll just stock up for now while everything's on sale.
Well, it's great. Mark, it's kind of the same question to you, but I know you've approached things, and you have a really large group, part of a huge group. So how does your practice differ right now, you think, from, say, the other people that have spoken to this point?
So we have a very large practice. We have about 39 offices throughout, mostly South Florida, some in North Florida. We have 550 employees, and that is an issue because we don't qualify, or we didn't qualify for some of the loans and grants that are given. What we did, though, is we wanted to really do what we could for our employees. So a lot of our smaller employees, we put on furlough, meaning we paid both sides of their health insurance to make sure they had health insurance. And since they were on furlough, they can get unemployment, including the federal government, $600 a week. So that actually really kept them in good stead and keeps them in good stead at this point. The professionals, the doctors, basically stopped taking their money, salaries, profit share, et cetera. The PAs were cut back a little bit, but they're still getting paid because we think it's important to keep our staff intact. And like Amy, what we're doing, we essentially closed to almost all visits. My practice is a combination of aesthetic, clinical, a lot of skin cancer, and research. Our research is being done primarily through virtual research visits now. We do a lot of telemedicine from the clinical, and we have followed up our aesthetic patients. We have not been able to see them, but we followed them up as necessary. And the plan right now is we're continuing in this mode, and we expect to continue in this mode for a great long while. essential services for dermatology, as Amy pointed out, really are things that are more emergency surgery, such as melanoma, or more invasive skin cancers, those blistering eruptions, and other severe eruptions. And really, that's the only things that we're seeing in the office.
Ask my panelists, everyone, since we're getting a little bit of feedback, everyone mute your computers unless you're speaking. So if everyone that can hear me, mute your computers instead of speaking. Allison, we can see you.
I think that's the audience view. They need to stop the audience view. They have to stop that. That's what it is. That's the feedback.
On the audience view, okay. So Corey, I see you, and thanks for joining us. Corey, I know you have some, you've done things a little bit differently in your practice. You want to kind of quickly summarize what you're doing and on the West Coast?
Well, we immediately implemented the policies that were put out by the CDC. I can tell you that we were probably a week in advance of everyone. I've actually talked to the CDC 3 times, including the admiral that's in charge of the strategy and implementation. And I can tell you CDC had no intention or no particular desire one way or the other to close down any doctor's offices. Their plan was to put out guidelines to do safe management of patients from the very beginning. So what you'll find is that these rules that are being implemented by your governor or your state public health officers of PHOs, state and local. And so they're taking guidance, obviously, from the administration, but the CDC's got documents and that are all published and available for every physician to safely see patients. And I don't mean the beginning of this ostensibly was to not interrupt supply chains for the hospitals and not be competing with them to buy equipment, supplies, gowns, and things like that, which is why the surgery centers got shut down right away, which we did, and we offered ours as right across the street from the hospital as an overflow center in the event of a surge. But we've been set up to do whatever we can. Now, at the same time, they've advised the local public, if you read the language of our local public health officer, it was pretty much emergency care only or urgent care only, or those that, in the opinion of the physician, deemed or warranted visits. So that the idea was to be pretty much shut down. At the same time they were doing that, they were allowing real estate agents to be essential and show homes and things. So I found some of this a little confusing and a little contradictory, but we've continued to see only a handful of patients. I think the main thing as we go forward, because this shelter in place concept as it relates to healthcare can't go on much longer. There's too much deferred healthcare in general, probably outside of cosmetic. Randy got frozen. Can you guys hear me?
How many?
Yeah, we can hear you. Randy's frozen.
Jason, how many refunds requests have you had over the last month or 6 weeks? I can tell you what we've had, but
you asking me?
That you already have surgery scheduled for.
Yeah, I was surprised, maybe 15%. And it was
15%.
only one. 15%, and it was only one facelift, only because she put it on her credit card, and she says, I don't want to pay for this until I have my surgery, and she left 20% deposit. But I was very surprised because we had a lot of money that we took in from the patient, and I thought that was going to use up operating cash. It didn't. I was shocked.
Yeah, we had budgeted for more refunds, but I was surprised that people had left their money on the books, assuming we can get rescheduled in a reasonable period of time, which we still don't know in Kentucky. Does anybody on the panel have any different take on that? Or if not, I'll go on to another question, and that's to Steve Perlman in New York City. Steve, how long, if we're in a shutdown mode for another 2 or 3 months, how do you think the practices, how do you think what will affect our practices, both short and long term?
Well, I don't anticipate be 2 to 3 months. I think we'll be significantly curtailed We may have to space out patients. We're going to have to put in place the ability to test patients. Again, the question, which is you're probably going to ask later, is how do we see patients and to what level do we expect require testing? Do we test every patient coming in for a filler or a Botox or a visit, or just patients for surgeries? And the other patients, we go by screening with quick history and taking their temperature. If it goes out 2 to 3 months, it's going to be a significant impact to not only our practices and our income, but also healthcare in general. I don't think they can mandate that you can now see people for medical reasons, not for cosmetic reasons. It's just like at the hospitals, they've curtailed everything but emergency. First, it was all surgery. First, they cut down almost all surgeries, and they came back and said, well, you can do emergency surgeries and urgent surgeries, and they now have to have urgent surgeries qualified by the department, saying what's really urgent. Cancer operation technically is not necessarily urgent, and the cancer is slowly growing. But a potential airway issue, that is a problem. So
well, I think Steve, I think you're on target. I think it's one of the things that was going to be really the main thing that I wanted to talk about tonight. Most of us that were eligible have already applied for PPP loans, and many of our colleagues have already gotten them. Some of us, like myself, have not received it yet, but we've been promised it. So hopefully we will get it. I know there's a shortfall of money, so I don't know how that'll affect us. But I know from the discussion group that we have that a number of people did receive the loans within the last day or two. Allison, are you able to hear us now?
Yeah,
Allison Avila?
Yeah.
All right, great. Great to have you on board. You want to tell us a little bit about just define the forgiveness as you understand it? And once we receive the PPP loan, when does the clock start ticking? How does the forgiveness work? Is it based on the number of employees or the payroll? Whatever you'd like to kind of advise everyone about their PPP loan would be greatly appreciated.
Yeah, so thank you for having me, firstly, and I'm sorry about that confusion earlier, but my computer was just not working properly. So if anybody has not applied for the loans yet, the SBA loans, I urge you all to do so, because if you need the money, do it now because they're running out. I have a lot of clients that have applied for it and have already been told that there's no money left. And I think that's the major point of this whole thing, is that even if you might not qualify right now, if you don't apply, there's no way you're getting it. So just apply. You can apply for the emergency, the disaster loan, as well as the PPP loan. So, do both. And you just can't use them both for the same thing, but you can apply for both of them. So the forgiveness part of it is only if you take the money, you use it for your payroll, and you have actually either furloughed someone or terminated them, and you bring them back on board. And so you need to use that money for the payroll in order for that to be forgiven. You can use it for other things. You can use it for, your mortgage payments, your rent, your, equipment or other obligations that you might have, but they will not forgive that portion of it. So you have to, whatever it is that you're using for your payroll will be forgiven. There's a calculation that they do. So 75% of it has to be done for payroll. 25% can be used for non-payroll related items. And then you have also like a 6-month deferral period, and then I think you can get up to 2 years, and it's at 1% interest. So even if you're not going to use this money for your payroll or something that would be forgiven, if you need it to roll your business or to fund your business for the time being, it's pretty much the cheapest loan that you'll ever get. So it's still only at 1%. So you should try to get it as much money as you can from them, because I think.
Allison, when does the clock start ticking, though? Because I've heard that it starts ticking. Ross said last night that it starts ticking 10 days after the origination agreement is signed. And I've heard other people say that you can kind of, start the clock when you want. I've heard other people say that it's got to be within May and June and no later than June 30th. There was a date like that in the bill. Can you kind of address that?
Yeah, so it's definitely within 10 days from the time that you end up getting that money. So as soon as you get that money, that's really essentially when the clock starts ticking. So you can't, it's not May or June or anything else. I mean, you get the money, then you have to, hire your people back, take them off of furlough, or use that money for some benefit to your business. But there's no lag time. It's almost like an immediate.
And as I understand it, it is 75% of it has to, the forgiveness part, 75% of the money that you want forgiven has to be used for payroll. Even of yourself, though. The doctors will qualify up to $100,000 maximum per year, prorated by the month. Is that correct?
Yes.
Okay. Very good. So that's the PPP part of it. I think we all understand that. I think we all have been through enough where we understand what happened during the first 2 weeks with sick leave and family leave and what we were obligated to there. We've already issued paychecks for that, most of us. So that's probably old news. But now I'd really like to go into what I think is the major part of what I wanted to, have this discussion center around. And that's to assume that in the next month that we all get back to business. What does that business look like? What do we need to do? I'm going to start with our practice consultant, Catherine Bailey. And Catherine, can you kind of summarize some of the things that maybe we should be doing right now, even before we open, and assuming maybe it's 2 to 4 weeks for some of us, maybe 6 weeks for others, maybe 8 weeks for others. What should we be doing right now in our practices?
Thanks so much for having me. Well, let's talk about the challenges that you're facing. The big one is the fear of the patient. It depends, like tonight, the White House came on, did a great briefing, and the message turned upside down. All of a sudden, the message was, okay, the states can open if they feel like it, and the governors have control over that. And that was a much more uplifting message than we've been hearing. Because I was afraid the media was really scaring the heck out of the consumer cosmetic patient. So even if you wanted to start, I didn't know if the patients were ready to start. So what I would personally do, can you hear me okay? I'm getting so much feedback. What I would do is join the conversation the patient's having in their head, which is this going to be a safe visit for me? And should I do it or should I wait? So why not do a video showing empathy for the patient and for their safety, and do a video of all the things you're going to do to protect them when they visit you. And that way, not only does the patient feel better, but you can take that video and put it all over your social platform. So other new prospective patients can see you, see how much you care about their safety, and then they're willing to come in as well. So that's the first thing I would do is calm the fears of the patient. The next thing you might as well do is if the patients don't come running back like you think they're going to, and you've got a lot of staff that you're paying who's sitting around, just like what Dr. Posner said, this is the perfect time to get some training on board. And here's, you know how everybody says, oh, all these pending projects we never have time to do? Well, here's your chance. Now it is time to ramp up your photo gallery. Now it's a great time to collect patient stories. And patient stories, you can ask your own email list as well as your social platform, please send in your patient story. And a good story is, this is the pain I was in. This is why I chose Dr. Smith, because that's why you'll want to choose him. This is what he did for me, and this is how great my life is now, thanks to Dr. Smith and the surgery I had. And that way, you can even use that promotionally. So you could say, anybody who sends in a patient story gets a $100 gift card towards their next visit in the office. Because just this week, for the last month, I've been saying, don't promote. It's in bad taste right now. I think you're better off just building a list and building your brand as a conscientious practice who cares more about the patient's safety than making it up. So anyway, now I think the table has turned. If the media doesn't keep scaring everybody and it goes more positive, I think you're in a good shape. But it is still something I would highly recommend. Not only additional training, like how to answer the phones, how to sell, how to convert consults, but also perfect your processes. Start from, here's our marketing. This is how we attract new patients. Then what's the next step? What happens when they email? What happens when they call? What happens when they opt in on the form? I would really perfect your processes so you are a well-oiled machine when you do open up again.
So those are great hints. And in fact, Catherine, we must have been listening to you because we were working ahead on newsletters to get them done months in advance. We've been working on our website like crazy to put better pictures up and better verbiage. We've been making videos. We have a videographer now on our staff, and we've been doing videos for our landing pages and also for our pre-op sessions. And these were all things, Catherine, that we really got lost in the weeds because we were just so busy and didn't have the time to think about it. So I still have about half of my staff in the office working on this. It's mostly the clinical staff that I've furloughed. The front desk staff and the people that can work on this type of thing, we went to the cloud on our EMR system rather than server-based, and we had been reluctant to do that. So we've done exactly what you're recommending. So those are incredibly important things. And, we may only have a few weeks more to do that, but I would encourage everyone out there to keep your staff busy, to stay in touch with them multiple times a day. I personally talk to my staff several times each day, and I'm doing video consults or at least pictorial consults, and we do the consults in our office and at home. And we've been doing a fair number of those, and we've been booking a fair amount of surgery. It's amazing. As one of my partners put it, our conversion rate on the virtual consults is higher than our rate otherwise. And maybe that shows that these virtual consults are really super motivated in what they're doing. And so we've been making, best use of the time. And I don't know, at least over the last 5 weeks, I've been incredibly busy, even though I wasn't doing the usual, doing surgery and seeing patients. So does anybody else have any, before I go into how we're going to do things once we get back, does anybody else have any cogent comment on what Catherine just said on the panel? So let's start with this. Go ahead, Amy.
Yeah, I just wanted to say one thing. I just finished reading the book Checklist by Atul Gawande. It was really interesting. And one of the things he said is that one of the things that they preserved on their checklist is that the team should all introduce each other at the beginning of a surgery so that everybody knows what everybody's name is and what their role is in the operating room. And also to discuss any concerns that each person might have. And it turns out that sometimes the anesthesiologist might find something out that the surgeon didn't know, or the resident found out something from the family that the surgeon didn't know. And what they found is that when they do that, they work better as a team, even if they didn't know each other before the operation. So even though I personally don't go into an operating room, we do procedures all the time, but I have a very large staff. And honestly, I don't know all of them. So we're going to take the opportunity to do Zoom meetings and combine people from different areas that might not get to know each other and just introduce ourselves and tell a little bit about ourselves so that we get to know each other a little better, so that when we come back, we're going to have more of a team spirit.
Well, that, we had the comment today. One of my girls said today that a couple of patients have been worried that we're going to try to squeeze them in when they come back because we're going to be incredibly overwhelmed with the backed up surgery. And so there are patients that are nervous that perhaps they're not going to get as much time and attention as they would have. So those comments that you just made about surgery and letting our patients know that we're not going to overbook, that if anything, we're going to try to separate things even more, is well taken. let's go back to Mark Hester.
I was going to say, make sure the staff is all on the same page. I think this is very important. There's a lot of reports out there from physicians that some of their staff, their page is not to be in the office. They're either frightened that they will be affected or infected if the patients are coming to the office, or some of them have other things in mind and would rather get paid for not being in the office. So it's very, very important that you have a clear understanding of where your staff is and make sure everybody is on the same page.
It's a good point. Mark, there will be some people that are going to prefer, maybe staying on unemployment because, as we know, at least for 4 months, the incentive of the $15 an hour incentive may actually put a person's actual hourly above what they actually make in the office for a temporary period of time. Do you expect some of that to surface and to be a problem?
Absolutely. I mean, I think it is happening already in some areas where people who have gotten the grants alone have tried to bring people back. The people don't want to come back because they're making more money in unemployment. So that's one aspect. But the other aspect that's even more concerning is that there have been reports of either patients or staff members even reporting practices to the police, to others, saying they're not following guidelines in order to either have a potential for a lawsuit later on or to stay at work. So these are things that we just need to be aware of that are happening around the country at this point.
All right, so Allison Avila, real quick, because Mark really kind of led into this. I know you know a lot about employment law. Are there certain landmines that are in front of us, both with our staff, I guess our patients? With every crisis, it seems that the lawyers kind of always come out ahead. Tell us what we need to worry about going once business starts back again with both our staff and our patients. And what landmines do we need to, how do we protect ourselves?
So interesting when Dr. Nestor was talking, when he was saying about, people coming into the practice and, if a patient came into you and you were not properly protecting the patient in terms of wearing, the PPE, and you didn't have your staff wearing PPE, she could essentially sue you and say, you're putting her at risk because you knew that there was a virus. You did not do anything to protect this person from contracting the virus, even though she's coming into you, wholeheartedly and whatever the case is. But so one of the things is that you have to make sure that your staff is always trained, because you as the physician and the employer is always going to be responsible for anything that your staff does. So you want to make sure that everybody is following protocol. And that doesn't have to just do with this particular virus, but it has to do with everything in total. You have to make sure, we're seeing some instances where we're anticipating that people are going to start filing lawsuits because of this whole thing, that they were not given the proper equipment. And so that would be if you're working with your employees right now and you're not giving them the proper equipment that they're supposed to be using, they could potentially sue, although they're going to, mostly be bored by workers' compensation, but they'll then try to sue like a manufacturer. They'll try to sue somebody else that would be able to be responsible for it. You have to make sure that you just have a lot of insurance. I have a client that was faced with this situation, ended up having to, let a couple of his employees go. It's a medical spa. But in the interim, while he was in the process of doing this, he ended up getting into a circumstance with a woman who was trying to make a claim that he sexually harassed her. And so then he was sort of in a bind because he wasn't sure, okay, well, how am I going to be able to fire this person or furlough her at the same time having this claim being faced against him. And sometimes you just have to be careful of what you do, but you have to make sure that you have the insurance for it, because most people don't have insurance for those kind of claims, like the sexual harassment and officers and directors liability and, your products liability and, every type of insurance that you can possibly think of, you really need to have, because it's really not expensive. And you
really
just have to
great advice. Dr. Clevens, we're starting practice. Let's say you're back in surgery. The governor of Florida says that things are a go. What does your practice look different? And tell me the ways, and I'm going to go right through the panel, and then we're going to open it to questions. Tell me the ways, Dr. Clevens, that your practice is going to look different on May 15th than it did on February the 1st.
Well, we're hoping for May 7th instead of May 15th, but I think we will. I think we will have learned a lot from this experience. In terms of marketing, like everybody else, we pivoted our marketing campaigns. We focused more on being empathetic and making efforts to connect with patients. We're seeing an increase in Facebook usage, Facebook Live. So I think moving forward, perhaps some of the tone of our marketing will change. We'll focus more on how can we connect and be empathetic with our patients. As far as employees are concerned, as well as patients, safety will be a key concern. How can we make sure we have ample hand cleansing stations and distancing? There's been a discussion by a real estate company called Cushman & Wakefield, and they've developed what they call the 6-foot office, and it prescribes concepts for how to keep your employees 6 feet apart from one another, how to route patients and traffic flow through the office, perhaps in a clockwise fashion or a one-way fashion, to help facilitate distancing among patients and distancing among individuals. So again, to try to keep that social distancing. We've had a lot of experience, as has been discussed on this panel, with both telework, telecommuting, as well as the virtual consult. We've had the same experience, interestingly, Randy, that you've had, that a lot of our virtual consults and teleconsults have actually been remarkably productive. It seems, as you suggested, they're highly motivated patients. It seems our closing rates are higher. So perhaps moving forward, the virtual consult is something we might implement as part of our strategy. And then finally, as we bring employees back to work, as part of the social distancing concept, we may find that a lot of work can indeed be done remotely. Our patient care coordinators have been working quite avidly over this past month or so period, doing a lot of their work from home. So again, perhaps we'll implement some telecommuting or some telework for our employees. So moving forward, I think we will have learned a lot from this experience. We'll be able to implement some of those policies and procedures.
So sorry about that. It's probably from my phone because I'm looking at text. But Dr. Posner, the same question for you.
So I'll keep it short. I think a couple of very specific things. One, slow down the clinic days. I mean, on a busy clinic day, I could see a lot of patients. I might have 60 patients on a clinic day, consults and follow-ups. That we obviously can't do that if we want to keep up with the social distancing. So definitely slow down the clinic days. Definitely more remote things going on. I'm thinking some of the post-ops don't need to come in and we can do FaceTime with them. So I think some of the post-ops will definitely be doing virtually as for the consults. The big, the elephant in the room is the pre-operative testing. Do we need to pre-op test people or not for coronavirus? Because if someone just is positive, we don't want to intubate. So I think those are the questions that need to come down. Our societies are really going to help us with some of those anesthetic questions. But certainly I think in the beginning, we're going to be pretty busy and going to have to try to accommodate the patients that we postponed. I don't know what's going to happen after that.
Well, we're going to get in. That's going to be my final question. Steve Perlman, same question to you. And you started into this a little bit ago, but let's just, what are you going to do differently? Are you developing protocols right now for your staff, or is someone on your staff developing protocols for how you're going to see patients? Are there new rules about surgery? Jason alluded, are we going to have a negative COVID test before you consider doing anesthesia on someone? How does it look to you?
Well, again, examining patients for office visits, that's one thing. Surgery is another. I'll talk about the surgical part since we have a couple of dermatologists on who will see a lot more patients face to face. For the surgical patients, we need to have the availability of testing. And you've got to have two variety of testing. There's the mucosal testing shows you have active disease, and then there's the serology testing showing IgM and IgG. You have to show that you actually have negative serology testing by nasal swab, show low IgM, no IgM, and that IgG, if someone is elevated, it's okay because they have already had the disease and developed immunity, but they're no longer able to transmit the disease. And then you have to make sure that they stay isolated between those two. It has to be 2 days before, between the 2 days and when you operate on them. And even then, you have to be careful. Everybody in the operating room has to wear protection. It was demonstrated that in China, the number 2 doctors that were affected and died of COVID-19 were ENT doctors doing nasal operations. So this is a very high incidence in anything done above the neck, especially the nose. Have to be extra careful and really have to do the availability and the accessibility to testing, which still is ideal and not reality right now, but hopefully within the next month or so, this can become something that is more available and accessible to all of us.
Yeah, and Steve, I think you're right. I don't know what that protective equipment looks like, though. And I saw Ivan Wayne maybe on as an audience member here, but he showed that it was sort of like the thing he showed was like the people that do total joints, almost like a hazmat type of thing. And I was thinking, oh, God, I can't imagine doing a nose that way. But, I mean, how protective do we need to be?
Well, I think it's hard to say for sure. Dr. Yangju Jang, who's practicing in South Korea, has a huge practice, very smart guy, and he's actually back seeing patients and operating. He's wearing an N95 mask with loops, and then he has a face mask over the entire thing. So you're protecting that way. And you want to change. You don't want to use aerosol sprays. You want to use topicals. In terms of you have to be careful with the way patients are intubated or LMA is placed in, which is actually safer than patients at twilight because they're not coughing in your face. And it's also a matter of making sure that you have a proper controlled environment and all the staff is protected.
All right, same question
Randy,
for you, Mark. Yeah, go ahead,
yes.
Mark.
I'm just, what Steve brought up something I think is very important. 2 things. Number one, when testing becomes available. We're not, unfortunately, even close to the situation that testing is widely enough available that we can get them for our patients when we need it. That's number one. Number 2, the problem is that we don't know. The data that's coming out now is that, number one, we know that asymptomatic patients can shed the virus. And that's, something we cannot, control. But also the patients that are going to get sick, they seem to have the most virus spread before they're symptomatic. And those are 2 things that unless we have testing and unless we can really know right before we see the patient what's going on, it's extremely difficult to control that. And it's going to be for a long time. And so it's not just our aspect that needs to be controlled with PPE, it's the patients as well, because the data is really showing that if the patient is wearing a mask, and that's not very practical if you're doing a facial assessment, but we may want to come up with something pretty unique to block off certain areas from the nose and mouth and be able to see other areas. But the patient needs to have PPE to protect the staff as well as the staff to protect the patient.
Dr. Moss?
Well, a couple of things, because Mark brought up some important points that are common wisdom but are not actually proven in studies. And I think this is in part something that we need to be much more participatory in, reading the actual studies themselves. The mask wearing phenomenon were familial cluster case reports from China that were that involved a completely, quote unquote, asymptomatic patient transfer. And we're not really sure if that's the case yet. That hasn't been proven. So I know it's the messaging that's out there to scare people, but until we get better scientific evidence, I don't think we need to be repeating things that we're not 100% sure of. That's messaging that we're repeatedly hearing. And the mask movement was literally 2 case studies that were familial clusters. And both of the families that were involved were in the environment outside of their homes and had potential exposure, even though they didn't have exposure to known sick people, had potential exposure outside of their homes. And we really don't know if those studies are accurate because of the data that's coming out of China being insufficient. So I'm not saying it won't be done. I think it's proper to, at least at this point, to wear masks to the extent that you can, obviously, with patients and facial examinations. But if you go to look, this has already been defined for us. The CDC has put out a very straightforward and rigid set of guidelines that we're all supposed to follow. I think that all businesses will be following some of these to some degree, but most importantly, we need to lead the way by doing it exactly as they've described. And, as it relates to staff, we've talked about this extensively, and I agree you have to have people buying into the concept. And if they're at-risk staff members, I just wouldn't advise them to come back in. Conversely, I have a fellow that has 3 roommates that work in the ICUs at the hospitals here. And although we have very low numbers of COVID patients, I just don't want him bringing that exposure potential into the office. So it really works both ways. There's no evidence of physician-based, at least in the U.S., physician-based transfer of the virus, to spreading the virus. But those are also studies that have to be complete or done, or it would be part of what we'll be doing in the surveillance part of it. But I would really be careful about spreading there's a lot of things that are being said now that are not supported by solid science. And I think that's really important, that we read the papers, study and understand them, and not just repeat things that are not carefully studied.
So something we're doing in our practice, or at least we're talking about, is trying to limit the number of people that come in, closing all the exam door rooms, trying to just say the patient, not family members, not children, coming with them for purposes of separation, keeping people in our exam rooms and out of our reception area as best we can. In other words, moving people along and not having long waits, separating our appointments, like Jason said. And then we hope that we have some type of testing where like a pregnancy test, we hope we have something that we can send it for a day or 2 before, as you mentioned, and that there's some sort of quick test. And we're even talking about whether we use one of our operating rooms at a time or both of them to try to cut down the traffic. And again, we have 4 of us, so that becomes difficult. But I'm going to go around. I have a final round of questions. Number one, and I'm going to just kind of go right through you very quickly, but the first part of this is, what do you feel about the economy as it relates to, say, the where we were after 9/11, or some of the other things that we've gone through, some of us that are older and more experienced? What do you feel we're going to be facing by next August or September? Not immediately, but by when we have pent-up demand, but by next August or September. And how many of you out there are worried about a second wave of this occurring in the winter, with people traveling from colder climates where it's flipped around, where they're in winter and we're in summer, and then all of a sudden they're in summer and we're in winter? So Steve Perlman, a question for you, starting.
Well, again, being in New York City, I saw a huge dip after 9/11, and then again at the financial. I mean, it's going to be much more devastating in terms of the financial impact. Initially, it's going to be a rush. A handful of patients who have to get the Botox, have to get the fillers, and have to get their surgery, they're going to come in. And after that rush, people are going to look back and see that the wallets are emptier, and they need to be more conservative about their spending. So there's going to be a long economic fallout. In terms of the process with our practices and medicine, this is going to go out. This is going to go out for 2 years. They're talking about, not talking about not even admitting Harvard, but not admitting students to come in as of September for next semester. So we have to get used to the new normal which is going to be extensive testing, keeping patients separated, treat patients less often, as well as hopefully be improved. And we have to stay protected for years to come.
All right, so Jason, the same question to you. Second wave, are we worried about that? And how do we feel about the economy in Florida? Again, I agree with Steve that we're going to have an initial rush of people catching up, already on the books particularly. But what is it going to look like in August, September, and October toward the end of the year?
You know, we've all a little bit older on this call, so we've lived through a couple of these dips. You know, eventually it comes back. We may have some short-term things, but it's. I want to make a couple of points. One, this is an election year, and Trump wants to get reelected. He is going to do everything he possibly can to get the economy back on track, which is good for us. Two, the travel industry is decimated. People are not traveling. So I think that may bode well for us doing surgery because people are going to be stuck home. I think they're going to spend their money with us. So it may be better for us. The cruise industry is shot, the travel industry is shot, and airline industry is shot, and that's going to take a while to come back. The meeting industry, Randy, is probably not going to be as great as it had been. So I think those are things that we really need to look at. So I think there's going to be pluses and minuses. I mean, you know, some people have done very well with this. By the gun store, he sold more guns in a week than he did in the last 8 months. So I mean, certain industries have done very well, and I think we'll do okay in the summer. It may not be back to where we were a couple of months ago, but I think we'll be steady.
Mark.
So I tend to agree with Steve. I think this is going to take a long time to come back. I think that right now we're looking at probably about a 15% unemployment rate. And if you think about, Jason, what you just said, I mean, in Florida especially, you know, the cruise industry, the airline industry, the hospitality industry, hotel is the engine of the Florida economy. And that is going to take a long time to come back. And I think there's reverberations across the spectrum and across the country. I think it will come back. It's just a question of how long. Airline travel after 9/11 took 3 years to come back. So just to give you an idea, and this is a much greater effect than was 9/11. So we have to be capable and we have to be flexible enough to deal with, and I think that's really the key issue, financially flexible enough to deal with a long-term downturn to keep in business. Because after the Great Recession, a lot of cosmetic doctors went out of business actually because they weren't prepared for it. I think we have the ability to prepare for a longer-term turn down and be able to structure our practice to be able to stay in business.
So, Catherine Maley, your thoughts?
I would recommend that you work on your brand, because what's going to happen if that kind of unemployment happens, and I was also around for the couple of recessions and an earthquake and all of that. When things like this happen, I think you're so right. There's a surge of patients who want this no matter what. The masses might take a break and sit back. But the whole world went online just now. I mean, for the last month or 6 weeks, all of us went digital. I think every practice needs to have a videographer on staff and some kind of roving reporter in your practice, and work on your brand. Because if this is going to get commoditized even more so than it is now, your brand is going to be the only thing that saves you or differentiates you from everybody else. And let me mention something about virtual consults. Now that we opened that door, I think they're here to stay. I think they're going to become mainstream, and I would get very good at them. But I would also make sure you have your processes set up just like you do in real life. I wouldn't do a consult and then sit outside the back in a week. I would literally get so good at this that you and your coordinator literally do the whole thing now and still try to convert right from that consultation. So that would be my recommendation. It's gone digital now. Oh, by the way, you can even use virtual consults as your let's call it your lead magnet. Like, let's say you want to advertise. I wouldn't advertise, specials, because that's what everyone's going to do. But I would work on your branding and then offer a complimentary virtual consult during a certain time, especially now while things are still unsettled, and then start charging for them later when things settle down. In the old days, I used to say to a doctor, don't allow virtual unless people live, let's say, 50 miles away. Now I would say, you know what, I don't think you can say that anymore. Let people do virtual if they want to, but then make sure your process is so good that you can still convert them digitally.
It's like you're tapping into our office, Catherine, because that's what we have as a videographer. For the first time, who was a news reporter, she's been great. And we have a website person now who's been great. And so we're really working that aspect, because I still believe that in the end, the strong will survive this. And that's the same thing that we saw before, that some of the weaker practices or less established practices have more trouble. So hopefully that's the way this thing will go. Amy, Dr. Taub, any thoughts about what we've been discussing about the economy and where cosmetic dermatology will be? Are injections going to be the thing that survives and maybe surgery lags, or is it going to be the other way around?
Well, interestingly enough, with the recession in 2008, what we found, we definitely had a downturn, but being dermatologists, we could kind of go heavy on the medical. Now, we could do that again now. The only problem is if people are unemployed and they don't have insurance, that could really cause a problem for our medical side that we always kind of move towards when we have a downturn in the cosmetics. The other thing that happened, though, in 2008 was that a lot of your patients, a lot of the plastic surgery patients were like, well, I feel, like I really shouldn't get a facelift right now because that seems so exorbitant, but instead I'll have some fillers and Botox. Of course, now that was like 12 years ago or whatever. Now everybody is doing that and everybody gets it. So I'm not sure how that will play out. I'd like to believe Jason's version of things, that things will pick up a little bit. Illinois is not dependent on tourism, so I don't think that will be a problem. And we're kind of like meat and potatoes, and I think that our patients will come back kind of more slowly. I think there will be an initial rush, especially for Botox. It's kind of like a haircut. Nobody likes being about it, but I think people are going to be, we're a little more conservative in the Midwest. I think they will be a little bit more careful. They will definitely want to see evidence that we're being safe and careful. I think by the fall and the winter, though, Jason made a good point. If people aren't traveling, I think it will take a long time for travel to come back. A long time. Maybe not until next spring or next summer, where people are really going to want to leave or go overseas or anything like that. So I think that they'll be here, which might be good because they're looking for things to do. Everybody's bored. They want to get out of the house. They want to get back to their regular life. I think that's going for us. It's a tough call. It's hard to say what's going to happen long term, but like we all said, we became stronger after 2008. I think we dominated because we've been around for so long and we do have a strong brand. So I'm hoping that we will continue to be able to survive.
So Amy, actually, I'm going to ask you a quick question. We have a number of questions from the audience, and I'm going to start there. Are you charging copays for teleconsults, telehealth?
Well, in Illinois, they have, I think they've made that illegal in Illinois. So
illegal?
Supposedly most of the insurance companies in Illinois have agreed to not have a copay required for any telehealth visits, at least until for the foreseeable future. I mean, probably when this is over.
Dr. Nestor, same question.
So no, we are not collecting copays.
No, it's not like that in Florida. We are charging copays. Patients are willing to do copays. I should say that what happened is CMS changed a lot of the rules. The rules for teledermatology or telehealth was very reasonable before. And what they did was they changed it to regular office codes, E&M codes that we use. And that's made it a lot more effective and a lot easier. But yes, we are allowed, and patients are perfectly comfortable paying their copay.
So I think I know the answer to this from Dr. Clevens. We have a question. Are you taking deposits for virtual consults? I think I know the answer to that, but go ahead. I assume that if you're taking deposits, I assume they're asking, are you scheduling surgery and then off of a virtual consult, listing them for surgery and taking a deposit? I think that's what they're asking.
Yeah, that's a good question. We're treating virtual consults in our office in the same fashion that we would other consultations in our office, in terms of following the same algorithm with our patient care coordinators reaching out to the patients during the virtual consultation. And indeed, if patients are interested in scheduling surgery and proceeding with surgery, we're scheduling them accordingly and taking deposits accordingly. It's of course based upon a confirmatory in-person consultation, but sure, it's just like a patient that might travel a distance to come see us. We might
Dr.
under
Moss,
better
same question for you. Are you doing virtual consults? Corey, are you there? I don't think we can hear Corey. Okay. Dr. Perlman, same question to you. Are you doing virtual consults?
Yes, I'm doing virtual consults, and we are not charging for the consults, although since I've had 2 people, no shows, we're actually taking credit cards that will be charged if they don't show for the consult. What we're also doing is if someone wants to schedule surgery, we'll take a deposit, then we'll tell them you'll be on the list, and you'll be put in for surgery when we're open, after we accommodate the patients who are scheduled for that time and patients who were rescheduled. You'll go on a list of when we can accommodate for surgery. If we don't want to give a deposit, happy to, as soon as you're ready to, see you in person, and then you can do it at that time.
Allison Avila, there's a question, are my employee physicians entitled to their share of the stimulus check we received? I assume they're talking about the PPP as a direct deposit from the government. I think we answered that before, but do you have any specific comment about that?
So it doesn't matter if it's a physician or whoever it is. I mean, if they're on the payroll, then yes, they're entitled to whatever it is that their pay is. So if you're using a portion of that money to pay the payroll, then they're entitled to the money.
All right, I'm going to just throw an editorial comment because before I forget it. So, Jason, I do agree with you. I think that there are going to be meetings that are certainly challenged. The fortunate thing is about both Global Aesthetics, which is my meeting, and South Beach Symposium, which is Mark Nestor's meeting, is we're late in the year and we're not a foreign meeting, so we don't have to travel across oceans. So we're hoping that people will just want to see other people so bad by November and by February that they're going to flock to Florida. So that's an editorial comment. We're keeping our fingers crossed. I do agree with you. I think travel is going to be more difficult, and people are going to really watch that a little bit closer. So, but anyway, a lot of the people on this panel are part of both Dr. Nestor's meetings, and I think everybody on this panel, in fact, is part of the Global Aesthetics meeting coming up in November. So hopefully we see a lot of the people that are listening in at that meeting, because we talk about a lot of practice management and marketing subjects, and it's a full track of the meeting. And a lot of these things are crucial. And I think by November, some of these things that we're talking about tonight will be expanded, and there'll be a lot more to talk about. So it's a complex issue. Does anybody, I'm just going to go through the panel and have everybody kind of summarize and give kind of a closing statement, unless there's, wait a minute, if I have any other questions, and I don't see any yet, but let me go into Q&A real quick. So I'm just going to let everybody go through and just, give a summary of of what your thoughts are about our discussion tonight. And we'll start on the left side of the screen with Steve Perlman from New York City. Your thoughts on where we've been and where we're going and what we need to prepare for in the next phase of this whole thing.
Well, there's nothing any of us ever could have imagined or prepared for. It's something practically different for the rest of our careers, that you want to promote patient safety, staff safety, quality medicine, and basically the panelists are all they're all top people. So the cream is going to rise to the top.
Let's hope so. Dr. Clevens.
I would agree with Steve's comments. Most important to protect your employees, to protect your customers, implement the best known guidelines, both for employee and customer safety, and invest in this. And then, as I said at the outset, it's an important time to play offense, not just defense. Define how you will outperform in the future. And now's not a time for a wait and see approach. And I'd echo everybody else's sentiments that these are amazing times that we never imagined seeing ourselves amidst.
Agree. Dr. Moss.
I think I agree with those safety things. I would say that we are all still doctors first, and to the extent that we can help with our public health officers, getting feedback to them, and also being an accurate microphone to the public, because what's being pushed out there in some cases is not correct information, even on TV, surprisingly. And as we move from this shelter in place everyone scenario, which has never been done before, it's an experiment, to what is a known way of treating epidemics, which is sheltering the sick and the exposed in place, it'll be really important that we help to educate our own patients about, staying at home if you're sick or if you're exposed, and the importance of that to keep surges from happening again. As we come out of this, remember, theoretically, none of us have viral antibodies, so it would be very easy to see secondary surges, because we really have very little exposure as far as we know. There may be much higher numbers of people that are antibody positive than we know about, but that's testing that's out there in the future.
I think I agree. You and I have talked about it in California. It may have been there since November, December, so there may be a lot more people that were exposed to it early on, because we're finding out that it was earlier and earlier, perhaps, that it entered the United States unbeknownst to any of us. Mark Nestor, your comment?
So I want to echo the most important thing is that for all of us, what we've heard is we need testing. We need reliable, quick testing that we do not just for the symptomatic, but for the asymptomatic individual, so we have a better sense of the science of how this is transmitted, and more importantly, for the protection of our patients, the protection of our staff, and the protection of our families. And we really can't, discount the issue that we all have to go home to our families, and we need to protect them as well. At this point, there are no good treatments for this virus. There's no vaccine in the near future. So we need to press our public health officials, our hospitals, et cetera, to make these tests available as quickly as possible, so that we can get on with a better area of our lives.
Agreed.
Allison, any comments to summarize?
Yes, I'm hoping that the world opens up, because I will be your first customer, because I know I will be running out for Botox and fillers as soon as this is open. So I have no legal advice at all. But seriously,
I like that attitude. Catherine, your thoughts?
Public people.
I would just say, as it comes to marketing and growing your practice, why don't you go with quality over quantity? So when you build your brand, try attracting, I would go up the food chain, quite frankly. You have to think about who can handle a recession or who can handle a dip. And it's not the young 20-year-old who wants to breast dog, you know? If you only have limited dollars and staff to work with, I would definitely get very targeted about a certain patient that can afford your services, because I don't think you're going to be able to see as many of them as you have been able to.
Very good. Jason?
Couple of points. Let's keep it short. One, I learned, stay away from bats. Bats are bad for us, okay? So everybody should stay away from bats, and certainly don't eat any bats. The second thing is everyone should be exercising. I want to say we're getting fitter, not fatter after the coronavirus. We've all seen these things coming across our email. Unless that's good for my lipo business. The other thing is spend some time on your practice. You know, throw a coat of paint on the wall. This is a good time to do it. The last point is, as Catherine just said, there's a return to expertise now. Who is the person that we're watching the most on TV? It's a 79-year-old guy, Fauci, right? So people are going to be looking for credibility now. They're not going to be looking for the people just out of practice. So really work on your expertise and your credibility, and work on your offices during this downtime that you probably will never have in your whole life.
Very good. And Dr. Taub.
Oh, sorry. Well, it's kind of all been said. I would add one more thing, and that is I think we all realize now that when we complain about all the little things that happen to us, or how hard we work, or how much we have to do, or how busy we are, we can see that we really do like our lives. We want to get back to them. So maybe there'll be a little better attitude, our own attitude towards work, our patients' attitude towards us. And hopefully we can be, I know this word has been beaten to death, but a little bit grateful about what we have, and try to approach it that way. I like to think more positively. I do think that our patients really want to get back to their lives. They want to come back to us. They want to go back to work. I think that positive energy that we have and the industriousness of most people will go through eventually, and we just have to focus on the eventually.
Well, that's great wisdom. From our point of view, I think the testing, and we had a couple of questions about that I think the testing may well be something that we put into every regimen, assuming we have some sort of quick test, like we do pregnancy, and we do nicotine tests before any type of flap surgery, facelift, whatever. And I think the testing is going to be incredibly important. I think that we're going to have to assure both our employees and our patients that, as Corey said, that we're following CDC guidelines, and that and that we're a safe practice, as Catherine said. There are going to be a lot of practices that probably don't chin to that bar, but I think we have to be the practices that do. And we have to give the impression, whatever that is. If it's limiting people in your reception area, ours is fairly big, but we still may, just move patients from, point A to point B very quickly, where we can isolate them. And I think that we're going to see a new norm in terms of when you go to the dentist. The dentist always has a mask on when they're working on you, and eye protection. Will we be doing that with injectables? I think so for a while. So I think that's going to be different. Will we have 3 or 4 people in an exam room, 3 family members with somebody? I don't think so going forward. Will we have children in the office? That's another thing to ask about, because again, it's the number of people and the distancing and fingers over everything. Will we have Clorox wipes in every room? Absolutely. Will we be wiping down the chairs after every visit even more than we have? I think so. Will we be showing patients that we're doing that inside the exam room with Purell or whatever? I think that's what we're going to be doing. So I think there is going to be a new norm for a while. I tend to be more optimistic than some of you on the panel. I actually think that Trump is going to push very hard to get something through the FDA very quickly on a vaccine. And I feel that there's a chance that we'll have a vaccine maybe in January or February. Now the effectiveness of it, we'll have to see. But, and maybe we'll get lucky and it'll work very well because that will open up the world again. That's really what happened with smallpox and polio and all of those things. We basically eliminated those diseases by having universal vaccinations. So I hope that that's where we're going with this whole thing. And I hope that we don't see a major recession, although my gut tells me that we need to monitor that very closely, and that will also play into what we do with our employees and the number of employees and many other things going forward. I do agree with Catherine that we do tasteful marketing at this point. I know some of our competitors may not, but we're going to try to keep a low profile and be informative, send out newsletters, work on the one thing that we can work on the hardest, our website, and try to put our best foot forward with all that. And, I know there were a lot of other questions that we didn't get to. We're going to try to do this type of forum, once a month going forward with the Aesthetic Authority. We'll see how that works. But it's been a lot of fun. I really appreciate everyone from the panel taking your evening when you could have been out at restaurants and bars and all the I know that Jason would have been out certainly at one of the Boca restaurants tonight. So I really appreciate you taking the time away from Netflix and reruns of the old Red Sox ball games. So anyway,
thank you for your sharing this very much.
I appreciate everyone's time.
Thanks, Randy. Thank you.
Take care.
Thank you so much.
All right. Thank you. Bye.
Thank you.
Bye-bye.
Great job, everybody.
Good night.
Have a good night.
Night.
Night.